Hello everyone, welcome to this webinar on elective surgery in high-risk patients. How do we anesthetize them safely? So my name is Latifa. I'm one of the senior anesthetists in Langford, and today we're going to see three different type of cases to understand how to tailor GA in difficult patients. So before we go into detail on how to anesthetize specific patient, I want you to think for a moment, how do you tailor anesthesia plan? So to organize your tailoring, you may want to think about the 3P rule, which is thinking about patient, procedure, and pathologies. And often those three overlap a little bit in terms of consideration. And then when you have thought about all the consideration regarding those patients, you can add all those considerations and think about what should we avoid to do, what can go wrong, and what we must do. And then you organize your consideration or your concern in order of importance. So the top one would be the one that would the most influence how you're going to anesthetize your patient. And from the consideration, then you can make your plan. So you think about pre-GA investigation. So does your patient have comorbidity? Did you find something abnormal at the clinical exam that would preclude you to do something? Is it an old patient that need more investigation? Because again, we are in an elective procedure, so we should take our time. And then you want to think about drugs that you can give, the logistic of the procedure. Are you going to do some X-ray and then move to theatre? So how are you going to move the patient anesthetized, for instance? And then which monitoring you want to use and you have available. So that means that you have to identify prior the GA if the patient have some comorbidity, because if he's got disease, maybe we need to prepare extra tests or medication in order to be able to plan which drugs and how we administer the patient, and also the timing of administration. So that's about setting. And the setting is different according to the timing that you're thinking of, like the setting for preoperative period, intraoperative and postoperative period would be different. And then you have to think about monitoring. So you need to decide which one you need and which one you have available, obviously, and how to assess the patient, so how to recognize that specific consideration you have identified prior the anesthesia might happen, which sign that would mean, for instance, if you worry this patient might be painful, how would you determine under GA that he would be painful? And then how to treat it. So which medication you have available, which one you would need, and that's about target intervention. So often there is algorithm that you can come up with before you start the procedure. So if your patient is hypertensive, what are you going to do? So it depends on the patient, obviously. If the patient have like a cardiac disease, maybe you would treat it very differently than if it doesn't. Often they might be nociceptive or have a change in depth of anesthesia. So how are you going to resolve that if it happens? And if they're hyperventilating, what are you going to do? So today we're going to see three different cases. So first, Kiki, big heart. So Kiki is a cavalier king child that we need to be anesthetized for a tiny mass removal. And then we'll see Lassie, that is going to be spayed, but Lassie has epilepsy. And Whisker, which got a dental disease, but also has history of chronic kidney disease. So through the three cases, I want you to think about how to prepare your patient according to the patient, the procedure, and the pathology he might have. And then we're going to try to identify, prepare, plan, monitor, and assess, and treat if needed. So Kiki is a 10 years old Cavalier King Charles female that's got a mass on the hock, and it's probably most likely a lipoma. On the clinical exam, she's got pink and moist mucous membrane, CRT is less than 2, heart rate and pulse rate are synchronous and a good quality, but Kiki is a bit stressed and the heart rate is 100. But then when you auscultate the patient, you find that Kiki has an apex systolic grade 3 of a 6 heart murmur. On the clinical exam of the chest, the respiratory rate is about 20, and there is nothing on the auscultation of the lungs, and the patient is not brachycephalic. The rectal temperature is normal, but she's a bit anxious. And she pain score 2 out of 24. So I'm sure by now you have loads of questions coming to your mind. So first of all, what causes heart murmur? Do I need to postpone the procedure? Do I need an echocardiography? And what the anaesthetic risks are? So what to do? So maybe we can ask a friend, Rosie, our lovely cardiologist. Thank you very much for helping me with this case. So I have Kiki, he's a 10 years old Caribbean child, and he's coming for a GA because he's got a little mass on the heart.
Okay.
And when I auscultated him, I found out he's got a grade 3 heart murmur. And I just wonder, what do you think about this patient?
Okay. Do you have any information about the kind of description of the murmur? Is it systolic? What's the location?
So it's mainly apical, and it's definitely systolic on the left side.
Okay.
And then it reverberates a little bit on the right side.
And do we know much more about this murmur? Has it been detected before?
So on the history, I can see that last year he was maybe having a grade 1 or heart murmur, but they haven't investigated.
Fine. So I guess if we're thinking about left apical systolic murmurs, I generally have 4 differentials. The 2 common ones, so mitral valve disease and DCM, and then the rare ones, dysplasia, so congenital abnormality of the valve, or endocarditis where we've got infection. Is he quite well?
Yes, he is. He's a bit anxious though, like his heart rate is about 100.
Okay. So I guess if he's an otherwise well boy with just a little lump, I feel like endocarditis is quite unlikely, particularly if we've heard this murmur a year ago. Dysplasia, I would really expect to have heard a murmur before, because he's an older boy now, so again a congenital abnormality seems unlikely. So we're probably down to either DCM or mitral valve disease, and he's a cavalier, and we've heard the murmur before, so it's much more likely that this guy's got mitral valve disease, because that murmur with DCM only really occurs when the heart's really stretched, so it's one of the last things we hear. And we're pattern spotting a little bit, we know he's a cavalier, so he's probably got mitral valve disease.
Do you think we should do an echocardiography, or should we postpone the procedure for now?
I think we don't necessarily need to postpone. It would be quite nice to know whether he has cardiac enlargement as a result of him having this mitral regurgitation. Because if he has cardiac enlargement, we might make some adjustments to our protocol, and we might consider delaying slightly if we need to start treatment. But if he doesn't have cardiac enlargement, I think we'd be very happy to go ahead. Grade 3, we're pretty much 50-50 as to whether they're going to have cardiac enlargement or not. So it would be nice to have at least a focused assessment, knowing whether he has a big heart or not. If we can't afford that, at least knowing is he high risk for failure. So does he have a sinus arrhythmia?
No, he doesn't, but he's very stressed. But his pulse quality is quite good, and he doesn't have any other issue reported by the owner.
So I guess if he were to have a sinus arrhythmia, I'd be really comfortable that he had quite early disease and wasn't on the brink of failure, because it would suggest our parasympathetic nervous system's in charge. The absence of that is less useful, because as you say, being anxious, that's enough to just increase his heart rate. So I think having a very focused assessment, just knowing if he has a big left atrium, would be quite useful.
Okay, that's fine. So to summarise, if he's got enlarged atrium, we need to rethink a bit what we're doing, maybe put him on medication. So that would be stage B2.
Correct.
Yeah, and then if he doesn't have any enlarged atrium compared to the ventricle, that means it's more likely to be B1, and then we can go ahead.
Yes.
Amazing. Well, thank you very much for this information. So to summarize, what can cause this heart murmur? So it's probably, according to the location, the breed and the age, most likely a mitral valve disease. The prognosis depends on the echographic finding, so it might need some treatment. So luckily you managed to do an echocardiography, and then there is most likely a mitral valve disease, stage B1, as you can see on the 3 video. Do I need to postpone the procedure? Not necessarily, because according to the focused echocardiography, as we say, it's a stage B1. So now, thinking about the consideration, so if we remember patient, procedure, and pathology, so the patient is anxious, and he's also geriatric, so because he's anxious, he would need a good sedation, and probably some IM injection as well. Because it's geriatric, if you could do biochemistry and hematology, just to have a look if there is any subclinical disease, would be great. So the IV catheter placement might be difficult, and then you probably most likely need an IM injection to reduce the stress of the patient. And the premedication is there to decrease the induction agent dose, which would be important in this patient because you want to maintain the cardiovascular system. So because he's geriatric, he's got a reducing cardiorespiratory reserve, which means that he's most likely at risk of hypertension and decreased cardiac output, but also hypoxemia and hypoxia, because he might have a reduce in lung capacity and elasticity. They also have a decrease in cognition function, which means that they are more likely to be stressed and increase their catecholamine release, which is quite a problem because it would increase the induction agent dose they needed and maybe the inhalant agent quantity they would need. They also have subclinical chronic disease that you can always or not always find on the blood sample, and they most likely have OA, which further increase the risk of pain. So when you think about the drugs, you want to use drugs that with a low cardiorespiratory depression effect, which potentially could be analgesic, but you also have to think about your fluid therapy plan. So now, because he's got a mitral valve disease, you want to reduce the risk of regurgitation to the left atrium, and for that you want to maintain or increase slightly the heart rate to reduce the diastolic time and therefore the ventricular filling. So if you reduce the diastolic time, there would be less blood coming back to the ventricle and therefore less to regurgitate. Also, you want to reduce the risk of vasoconstriction. So that's why we suggest not to use dexmedetomidine on those patients and most likely ACP, because you might want to promote a bit of vasodilation to increase the ease of blood coming out of the aorta, but also to promote a bit of increase in heart rates. You want to think about fluid therapy as well, probably needed to be restrictive, but you want to make sure as well that you're not too restrictive, because if you become hypovolemic, that would be another problem. So now he might be a bit painful because he might have a bit of OA that you don't know about. Now you scored him and he didn't score very high. But when you think about an analgesia plan, you have to think about treating the actual pain, but also preemptively and preventively what pain the procedure is going to do. And for that, you have to make sure the plan is multimodal as much as possible. Multimodal meaning that the different molecule you're going to use would act at different sites along the pain pathways. Again, because of the procedure, the risk of pain, which is quite limited on this patient, but I would say probably like moderate pain at most. Now, in terms of consideration, if we have to classify them through the ladder, so my more important concern is his heart disease, and then his behavior and his age at the same level, and then the fact that he might be a bit painful during the procedure. So let's talk about drugs. So in terms of anesthesia plan, for the premedication of this patient, as we said before, he might be quite anxious, so you might want to consider giving an IM injection, and you can give acepromazine at 0.01 to 0.03 mg per kilo, mixed with buprenorphine at 0.03 mg per kilo. So why those two drugs? So they have pretty much the same duration of action and onset, and ACP is a very good addition for sedation for patients with mitral valve disease because of the little vasodilation that you get from it and the response in increased heart rate. So you promote a decrease in diastolic time and also the exit of the blood because of the vasodilation. So that's, in a sense, would reduce the risk of regurgitation on mitral valve disease. And buprenorphine doesn't change that much the heart rate, so you maintain a higher or normal heart rate with this plan. Now you can consider giving paracetamol at 50 mg per kilo per IV, when you have an IV before you start the surgery. And then you wait in the calm, and you can consider pre-warming the patient because it's old and he might become hypothermic. Now, I didn't suggest any non-steroidal in this patient because it's an old patient, and if they become hypertensive, it might damage their kidney. And we're not very good at monitoring kidney disease because often we found that they have a problem when it's already too late. So non-steroidal is not precluded in this patient, but maybe to consider to give it after the procedure. In terms of induction of anesthesia, propofol would be a good addition. Maintenance of the GA with inhalant, either sevoflurane or isoflurane. And then consider doing a local block, so you can do a ring block, which is quite easy to do, inject around the mouth or around the leg, with either bupivacaine or lidocaine at 2 mg per kilo per hour, and then Hartmann at 3 mg per kilo per hour. So what do we want to monitor in this patient? So heart rate, respiratory rate, and temperature is a must, is also the law. But you may want also to monitor the SpO2 because they're likely to become hypoxemic because they're older patient and the cardio respiratory function is reduced. Same for mean arterial pressure or the Doppler. That's quite interesting because they can become hypertensive, and you need to know because you need to treat it because they might have a kidney disease that you don't know about, and they have less protection against hypertension on their kidneys. The ECG could be interesting, especially because he's got cardiovascular disease, but it's okay to do without it. But if I had to choose, I would choose probably heart rate, respiratory rate, temperature, mean arterial pressure, Doppler, and SpO2. So what can go wrong? It can become painful. So in that situation, you want to give some boluses of methadone at 0.1 mg per kilo by incremental dose up to 0.3 over 4 hours. So I know I suggest to give buprenorphine to start with, but it's probably more theoretical that partial mu agonists antagonize the other opioids, the other mu agonist. Personally, I never had any issue with this. It does work just after buprenorphine. But otherwise, you can give fentanyl boluses as well at 2.5 to 5 microgram per kilo. So those boluses can make the patient stop breathing, but that's okay. You can hand ventilate and decrease inhalant because they're both drugs that have max brain effect. Now the patient can become hypertensive, and they often become hypertensive, hence you have to monitor the blood pressure. So that would be the target mean arterial pressure. So if they become less than 60 mean arterial pressure or less than 90 on the Doppler, you need to do something. So first line is to reduce inhalant if it's appropriate. But you can consider giving mini fluid boluses at 5 ml per kilo over 5 minutes. And if you're responsive to the first bolus, you can repeat only once. And if this is not enough, you can consider giving a dobutamine or dopamine CRI. They use the same dose, so 1 to 10 microgram per kilo per minute. It's important that you give that as CRI, constant rate infusion, and not too fast, because otherwise they become tachycardic and they can develop ventricular tachycardia. It's not a terrible drug, you just need to give it in a controlled fashion. But it's a drug that I would advise you to have in your pharmacy. Now, if you have bad recovery, that's possible, that happens, especially when they're a bit old. You want to ask yourself, are they painful or are they disorientated? So if they're painful, you give analgesia such as methadone or fentanyl. But if they're disorientated, you may consider giving some boluses of propofol, 1 to 2 mg per kilo. So moving on our next case. So the next case is Whisker. He's a 12 years old, the domestic short hair, main neutered, and he's got CKD stage 2 with moderate tartar. So Whisker is coming to you because he's got a bit of tartar and then he needs descaling basically. So in the clinical exam, mucous membrane are pink and moist, CRT is less than 2. Heart rate and pulse rate are synchronous and good quality and of about 150. On the heart auscultation, there is nothing to find. On the lung auscultation, it's a bit hard because he's purring, he's a happy cat, but the respiratory is 20 and there's nothing to add. His rectal temperature is normal, he's very relaxed and alert, and his pain score is about 2 to 24, would mean that he's not painful. Unfortunately, as you know, he's got a CKD, iris stage 2, that was diagnosed 2 years ago, and he had his last blood test a year ago. There is no change in water, food intake, no vomiting, no halitosis, and he's on renal diet. So I'm sure, again, a lot of questions coming to your mind. So should I do further analysis? Do I need to postpone the procedure? Do I need to start fluid therapy before GA? Can I give non-steroidal? So what to do? So how about we call our friend Leo the Medics? Hi Leo,
Hi.
Thank you very much for accepting to answering to my question.
A pleasure.
Thank you. So I have a 12 years old domestic short hair, male neutered, that is coming to me because he needs a dental descaling.
Okay.
And he's got a history of iris stage 2 kidney disease. So my question is, do we want to do further analysis, or do we need to postpone the procedure? Do you need to start fluid therapy before the GA, and can we give a non-steroidal?
Cool, perfect. So it's great that you've already staged the cat. So we use the iris staging to stage cats appropriately with CKD. And yes, there's probably a small amount of work that I would do before the anaesthetic. And for cats with known kidney disease, really, in an ideal world, you'd have some biochemistry. So really looking at your renal values and identifying whether that's changed significantly from last time. I think that's going to be important because if the CKD has progressed a lot, perhaps it might just change what you do just there and then in terms of whether that needs a bit more workup and maybe why it's changed. If it hasn't changed significantly, then on blood work that wouldn't necessarily stop you from doing a dental. A blood pressure would be really important, knowing whether patients with CKD have hypertension is important at any time, and of course important for an anaesthetic, because in an ideal world that would be controlled prior to the general anaesthetic. I think if you were doing an elective dental and you had time to, you could consider doing urinalysis as well. I think in an urgency that wouldn't stop you doing an anaesthetic on a cat with CKD, but when we stage cats with CKD, we include their urine as part of that investigations. Things like a USG and a UPC can be very useful. And the use of NSAIDs is obviously going to be part of our pain plan for cats, which is really important. And there's reasonable literature to suggest that cats that are stable, well hydrated, and that are normotensive would be able to receive non-steroidal anti-inflammatories. I think things that would make me more concerned in that regard would be if they've had hypotension under the anaesthesia, if their CKD has changed stage dramatically recently, and again, of course, whenever we give NSAIDs, we want them to be eating and without any gastrointestinal signs.
So you would suggest that we give the non-steroidal after the recovery, after the GA?
I think typically that would be a useful time to do it, because then you'll know whether they've been hypotensive, and if you are using fluids during the procedure, I guess one consideration just to have before doing that would be, because obviously often it's elderly cats with CKD, these cats also may have underlying heart disease, so that's a consideration. But if you're using fluids during the procedure, have had no problems during that procedure, and the renal values haven't really changed at all, then a cautious use of our NSAIDs is a reasonable consideration.
When you say renal value won't change, would it mean that after the GA we should repeat the biochemistry, or the one from before?
The one before, yeah. Because I think if you've gone from CKD stage 1 to CKD stage 4, firstly, probably a dental's not necessarily the first thing to do, but it might stop you using an NSAID, because, as we know, NSAIDs can be nephrotoxic in certain situations anyway.
Great. And what about fluid? Because obviously this cat is mildly azotemic, probably. Would you suggest to give some fluid before we start the surgery, or would you just leave it as it is?
I think it all depends on lots of other aspects to the case. So firstly, if the cat's very well hydrated and you're happy with that, if the cat, in those situations, you may not need to. if you know it's going to be a routine procedure, you're comfortable doing dentals, you don't think it's going to be any longer than necessary, the cat's come into that eating well, perhaps it's something to have ready in case maybe you need to utilise fluids for a fluid bolus in a hypotensive situation, but you wouldn't have thought you would need it in a very well hydrated cat having a routine procedure.
Do you mean before we start the procedure? Because we
before.
routinely put them on fluid oven,
before.
and then I think that's important that when they are anesthetized, they are in fluids.
Yes.
Okay.
Yeah.
Cool. Perfect. Okay. Well, so to summarize, should I do further analysis? Yes. So you do a biochemistry and hematology, urine analysis, and blood pressure measurement. So the results of the biochemistry show that the creatinine is slightly elevated, but is underneath the value that you would be worried about. Same for the phosphorus and the SDMA. So he's got mild azotemia, but is quite stable. So in terms of urine analysis, results are normal. The UPC is underneath the value that would be worrying you. So there is no proteinuria, and there is no need for further treatment. For the blood pressure measurement, the Doppler indicates 150, which means that the patient is not hypertensive. So, do I need to postpone the procedure? Evidently, no. Do I need to start fluid therapy before GA? No, because he's not dehydrated. Can I give non-steroidal? Yes, but we would give it after the recovery if the patient is not hypertensive. And the dose recommended would be much lower than usual. So if you were thinking of meloxicam, for instance, which is quite extensively studied, and there is a lot of report about it, so it's quite a well-known drugs, I would probably go for 0.05 mg per kilo, and you could go as low as 0.02.25 mg per kilo as well. So go ahead. So we go ahead. So let's think about patient consideration. So obviously he's a small patient, so he's likely to be hypothermic. So when you may think about pre-warming, like we discussed previously, maybe a heat mat and a bear hugger ready, and try to be conservative with the fresh gas flow. So let's talk about pathology now, consideration regarding pathology. So he's got CKD stage 2 and tartar. So if we think about CKD, we need to maintain the blood pressure a bit higher than usual because you want to maintain the perfusion. So often those patients might have a slightly increased blood pressure to maintain glomerular filtration rate, which is a normal adaptation after CKD. So we suggest to maintain it a bit higher. So if it was a Doppler, I would say probably higher than 100. So we need to think, if we think about tartar, so he might have dental pain, he might be a bit dysorexic. Also, because the teeth are less stable, when you intubate the patient, there is a risk of dislodge of the teeth and then being aspirated by the patient. There's actually a case report that's just been published about this. So when you talk about choice of drugs, so you need to give drugs that limit the depression and the blood pressure, use the maximum effect of the drugs, and obviously multimodal analgesia. And as I said before, analgesia is about treating actual pain, but also preemptively and preventively. So let's think about the procedure. So the procedure again might be painful, there might be a bit of bleed, and there might be disconnection of the ET tube. So for these two, the last two, you can't do that much apart being prepared. But for pain, you can preempt it. And again, the choice of drugs should be directed by using multimodal analgesia. So let's organize our consideration. So the top one would be the fact that he's got kidney disease, then that his weight mean that he's not a big patient, so he's a high risk of hypothermia, and then pain and bleed, and all those because of different things. So moving on the anesthesia plan. So this patient would be probably compliant enough to place an IV catheter in a calm situation. So you probably could just give all the drugs pre-meded IV. So I would recommend to give dexmedetomidine at 3 micrograms per kilo because it's a good analgesic, a good sedative, and also because he increased a bit the blood pressure, which could be helpful because, as we say, we want to maintain the blood pressure slightly higher. This is only if the patient is obviously cardiovascularly stable. If your patient is very hypotensive or very sick, dexmedetomidine is to be avoided. And then you can add some methadone to promote analgesia, and it would last the duration of the procedure again. Now, the effect of dexmedetomidine is quite interesting because it would it probably reduce the heat loss because of the vasoconstriction as well. And because with this patient we are a bit worried about hypothermia, that's another reason to use it. You can also consider pre-warming with this patient again because he's cold. He's going to be cold potentially. In terms of induction, you could use alfaxolone to effect, but you could also use propofol if you want. Maintenance, same like inhalant, either way, it doesn't really matter. Local blocking dental procedure is essential. Make sure you don't go above the toxic dose because cats are very sensitive to local anesthetic, specifically lidocaine, and make sure you don't give it intravenously. And then again, Hartmann's 3 ml per kilo per hour. So what to monitor for Whisker? So we need to monitor the mean arterial pressure or the Doppler. It's essential. If they become hypotensive, it can worsen their disease, as well as if they become hypertensive. So we need to monitor those patients with mean arterial pressure or Doppler. Heart rate, respiratory rate and temperature, again, it's a must, it's the law. And SpO2 could be good, ECG could be good. ECG mainly because they have a kidney disease, so they may have renal impairment that leads to electrolyte imbalance. But if I had to choose, I would choose mean arterial pressure or Doppler and heart rate, respiratory rate and temperature. So what can go wrong? Again, they can become painful, same as before, boluses of 0.1 mg per kilo of methadone, up to 0.3 mg per kilo over 4 hours in total. You can give boluses of fentanyl, 2.5 to 5 microgram per kilo. Again, they can stop breathing after those boluses, so consider decreasing inhalant and hand ventilate the patient. They can and they will become hypertensive, specifically because our target of mean arterial pressure that are acceptable are much higher. So we would suggest often to maintain the mean arterial pressure above 70 or the Doppler above 100. So you need to monitor it to know that. If it happens, you want to reduce the inhalant agent if it's appropriate. But if not, you may consider giving mini fluid boluses of 5 ml per kilo over 5 minutes. And if you're responsive, you can repeat it once. But if it's not enough, consider giving ephedrine by boluses of 0.1 to 0.2 mg per kilo IV. So you can repeat ephedrine twice, and it lasts about 20 to 30 minutes. Now you can have bad recovery, and then the bad recovery could be because the patient is painful, but also because it's disorientated. So in those situations, dexmedetomidine is quite useful because it is an analgesic and is also sedative. So the last case is Lassie. She's a 2-year-old border collie female, entire, and she's got idiopathic epilepsy, but also separation anxiety. And she come to you because they want to spay her. So on the clinical exam, mucous membrane are pink and moist, CRT is less than 2 seconds, heart rates and pulse rate are pulse synchronous and good quality, and the heart rate is 80. On the heart auscultation, nothing to declare. Same for the lungs auscultation. She's got normal temperature, but she's very anxious, and she pain score 1 out of 20. Now we know that she's got idiopathic epilepsy. She's on phenobarbital twice a day, and she only have 1 or 2 seizures a year. So imagine again a lot of questions coming to your mind. Should I do further analysis? Should I stop the treatment pre-GA? Does stress increase the risk of seizure? Is the dog more likely to seizure peri-GA? What do I do if it's seizure? So what to do? So again, let's seek help to a neurologist, Faye. Hi Faye, thank you for answering to my call. I have 2 years old border collie that is been diagnosed with idiopathic epilepsy, and she's also have anxiety separation, and she needs to be to have a GA for a neuroectomy. So a few questions probably. She's actually on phenobarb, and she hasn't seized much for the last 2 years. So she had maybe 1 or 2 a year. So would you say that is well controlled?
Yeah, absolutely. So ultimately the main questions I always have when I have an epileptic case coming to see me and I'm planning to do an anaesthetic is how strong is the strength of the diagnosis initially? So am I really happy they've definitely got idiopathic epilepsy? For young border collie that's having seizures and it's normal in between them, yes, absolutely, it's most likely epilepsy. But things that would probably change my anaesthesia plan is realistically I'm quite unlikely to find a structural brain disease, but I really want to make sure my initial investigations and blood work are quite concrete, so particularly excluding things like a portal systemic shunt that would change my anaesthetic plan. Otherwise, yes, from a phenobarbital point of view, I really want to make sure that they're on that prior to the surgery and well controlled with their seizures as much as possible before going ahead with any form of anaesthetic. But I would agree that sounds well controlled. Generally with seizures, what we aim to do is have kind of a 50% reduction in the frequency of seizures, or ideally less than 1 a month, and she's definitely in both of those categories. So yeah, that sounds very, very sensible.
Oh, thank you. So do you think I should do further analysis like a liver enzyme checking or concentration of phenobarb?
So I guess with the phenobarbital, as long as she's well controlled, I don't really mind what the number is, because the dosage she's receiving, each dog will metabolise that dosage differently. Generally, we aim for it being in a number between 20 to 30. It's really unlikely this dog's at toxic levels unless she's been on really, really high amounts orally. But given she's got no other clinical signs, probably doesn't change what we do. And we know she's well controlled based on her seizure frequency. So even if she was at 20, that would be fine for me compared to a dog that was seizuring loads and at 30. So I think it's a little bit of there's a nuance about that, I suppose.
So no blood test needed then?
No, as long as her initial blood tests, so looking at doing ideally a haematology, a biochemistry, a fasting blood glucose, and a bile acid stimulation test, with the most important thing being getting the postprandial bile acids. As long as they are all done at her initial diagnosis, and she's had probably regular ones alongside her normal EpiPhen monitoring, I'd be quite happy that she could proceed for anaesthetic.
And so more clarity, that's to make sure that she doesn't have a shunt.
Yes.
Okay, great.
Yeah.
Thank you. So do you think we should we continue the treatment pre-GA?
Definitely. So we often have this, obviously we deal with lots of epileptic patients here as well. We would usually give them, even on the day of their anaesthetic, a small ball of food with their medication inside. And if we really can't get them to eat, obviously there is an injectable formulation of phenobarbital which works quite well. So I always try to stick to as routine dosaging of all of the medications. And that's something to bear in mind if they're on medications which are due whilst under the anaesthetic as well. We want to try and stick to that routine as much as possible.
So we should arrange for the GA to be happening maybe 6 hours after he's been given the medication. So he receives the medication also, he's not at risk of regurgitation because he ate too early. Great.
Yeah.
And do you think stress can increase the risk of seizure? Because he's got anxiety, separation.
Yeah, that's definitely an interesting question. One thing that we see a lot with epileptic patients is increased anxiety of the dog and the owner, and maybe that's because of the breeds that we commonly see epilepsy in. Obviously, collies are quite highly strung breeds naturally, but we know that then in humans as well, we can often see some behavioural changes in long-term epileptics, whether that's due to the medication, the action of seizures, them worrying about their owners from a dog perspective. So it's a little bit of a chicken and egg scenario, but we know from humans that it's quite convincing that there are stressful events that can trigger seizures. And we also know that the hormones that are related to stress in humans can correlate to being higher at risk of seizures or just naturally being higher in seizuring patients. So it feels really valid that we see that in dogs. It's just really hard to investigate that well in dogs. So yes, being in a hospital is quite stressful. This dog sounds like it's going to be a high risk one as well. So we certainly want to manage that as well as the seizures whilst the patient is in.
Thank you. And how about the risk of likely seizure per GA?
Yeah, so actually the most common time frame we tend to see seizures is usually when they're recovering from the anaesthetic, and they are reported to occur under the anaesthetic as well. it's not really clear from the literature how often this actually occurs. And usually the medication we're giving them is an anticonvulsant. So if we have a patient that comes in actively seizuring, as everyone knows, often the first one we'll jump to can even be propofol, and we're using that as part of our induction agent. And there's also inhalant anaesthetics are to a degree an anticonvulsant as well. So it's fairly unlikely under the anaesthetic, but certainly plausible. In the recovery period for us is when we see it most commonly, which is why for any patient that's in the hospital, if we know that they're at risk of seizures, we always want to have a really good seizure plan in place and be prepared with the medication readily accessible for those events if they occur, because there is a chance that they're a bit more likely to occur in this specific patient.
I think in the literature I didn't see any case report of any kind for patient receiving a GA having priorly been diagnosed with idiopathic epilepsy. What I found was some patients developed seizure activities under GA with no prehistory of those, so maybe just the drugs that we're giving. Thank you very much. And what do I do if it's seizure?
So we want to be really convinced they're a seizure for the first off. So if that patient hasn't had its anaesthetic yet and it's just in the hospital and is really convincing it's a seizure, great. And usually in that instance, I would use something like a benzodiazepine, and we tend to use midazolam. The nice thing is if you haven't got an IV yet in that patient, you can give that intramuscularly as well as intravenously. Or if you did have an IV and it's come out in terms of paddling, then at least you've got another way to access there as well. However, in that recovery period or whilst they're under the anaesthetic, it can be really confusing to know whether you're seeing now side effects of the midazolam, because often they can be quite dysphoric, or if they're even seizuring at all. So that's where we change things a little bit. Sometimes we're usually quite led by the anaesthesia team as well, but often we would use things like dexmedetomidine instead. And obviously we've got propofol on standby for those cases as well. And usually around the recovery period, luckily you've got all of your things for intubation readily accessible too.
But let's say his seizure just before he's been anaesthetised, would you think it's a contraindication to continue for the GA, or would you just continue?
No, I would continue. I think, unfortunately, we've got no good predictors of when this patient is going to seizure, and we know that there could be a stressful trigger. So there's probably a limit to what we can do as prevention for further cases like this as well. Ultimately, if that case had actually been, if you told the owner the patient's had a seizure now and they went, oh, actually, he had 3 seizures yesterday I didn't tell you about. It's a slightly different situation, but for such a well-controlled epileptic, I'd be quite happy to continue.
Well, thank you very much, Phil. That was very interesting, and I hope you found that. So to summarize, should I do further analysis? No, there is no blood needed in this patient. Should I stop the treatment pre-GA? No, we have to do as usual. Does stress increase the risk of seizure? Potentially. So it's important that we reduce as much as possible the stress of the animal before he comes to us, but also when we handle them. Is the dog more likely to seizure peri-GA? Very anecdotally, but you need to be prepared. So what to do if it's seizure? We need to have a plan ready, and depending on the stage of the peri-GA situation, using propofol, midazolam, or dexmedetomidine. And it depends also obviously if the patient have an IV catheter. So if we think about consideration, so pathology, so the patient has idiopathic epilepsy, which means that he's got a high risk of seizure. So when we think about the plan, we need to avoid drugs that would reduce the seizure threshold, and we need to be ready, and we need to be able to recognize when the patient is seizuring under GA, if it does. In terms of procedure, pain is a major concern, as well as bleeding. So if we think about pain, we need to find drugs, again, that would potentially promote analgesia for when it happened, but preemptively and preventively, and it needs to be a multimodal analgesia plan. Moving on the consideration, if we go back to the ladder, so my main concern in this patient would be pain and then idiopathic epilepsy, behavior and bleeding at the same level as idiopathic epilepsy. So when it comes to the anesthesia plan, for the pre-medication, probably an IM injection would be a good idea. So dexmedetomidine, for instance, at 7.5 microgram per kilo. You can go up to 10 if you want. Add it with some methadone, 0.2 mg per kilo. You could give non-steroidal preemptively because it's healthy and it's a good analgesic. You can also add some paracetamol as well, either Peros or IV, probably IV if it's just before the GA. And then you wait in the calm for 20 to 40 minutes after you gave the IM injection. And when he's well sedated and has an IV catheter, you can move on the induction. So induce with propofol to effect, maintain with either SIVO or ISO, local block if you can, like a tap block or an epidural, or even a line block if you can't do any of those two above. You can use bupivacaine or lidocaine, and then put her on Hartmann at 5 ml per kilo per hour. So what to monitor for Lassie? So you want to monitor the entire CO2 because it's very useful to know if it's seizuring. So if you have a seizure activity under GA, they don't always move their leg or have any clonidia or anything. They can, but they don't always. So having entire CO2 plus monitoring heart rate, respiratory rate and temperature give you a lot of information because they have an increase in muscle activity and metabolic rate, so they often have an increase in respiratory rate, temperature, heart rate, and entire CO2. So that's why it's quite useful to have. Now, it's not a necessity, but it would be a good thing to have. An SpO2 and mean after pressure again would be nice. But if I had to choose, I would choose entire CO2, heart rate, respiratory rate, and temperature. So what if they become painful? So again, methadone, fentanyl as before. What if they seizure under GA? So what would you see? As I said before, you have an increase in respiratory rate, heart rate, and tidal CO2. You might witness a decrease in depth of anesthesia, so they become a bit lighter. They can do some paddling, very anecdotally. In that case, midazolam as an IV injection would be a good thing at 0.3 mg per kilo. Now, after you give midazolam, they might stop breathing, but that's okay. You can hand ventilate them and wait until they become more settled. They often have bad recovery, border collie, especially when they have anxiety, which is why having dexmedetomidine on board on the plan is a good thing. They can seizure the recovery, they can be painful, or they can become disorientated. So if the patient is healthy otherwise, dexmedetomidine is a good addition because it basically does all the three. So it's sedated, it's a sedation agent, so that's helpful for disorientation. It's also an analgesic, and it also helps to stop seizuring. If that is not enough, consider giving propofol at 1 to 2 mg per kilo IV, and then midazolam if it's not enough. The reason why I didn't put midazolam on the top of the list is because if you give midazolam to a patient that is painful or disorientated, the situation is going to get worse and he's going to be even more disinhibited. So start by dexmedetomidine. So that is it for today. Thank you very much for your attention. You'll find attached some individual PDF in the form of cheating sheet for the specific cases we took today. Do not forget to adapt your plan according to the comorbidity of your patient. So for instance, let's say you have a patient with mitral valve disease and idiopathic epilepsy. In this situation, you cannot use the plan that I gave you because they have mitral valve disease, so you should not give dexmedetomidine. So you have to adapt for each patient, but I thought that would be a good cheating sheet for you. Enjoy. Thank you very much for your attention.